Good evening, everyone. I am Delegate Jheanelle Wilkins, and I represent District 20 in Montgomery County. On behalf of our chairman, Delegate Darrell Barnes, and the 57 members of Legislative Black Caucus of Maryland, thank you for joining us. For the next 90 minutes, we will look at saving Black lives during this pandemic and beyond. You are going to get the facts and a plan for action to save Black lives. Maryland's Legislative Black Caucus was founded in 1970 for a time like this, to be the voice of Black Marylanders and to champion state policies that advance our community. I am joined by my co-host, Delegate Stephanie Smith from Baltimore City.
Thank you, Delegate Wilkins. I'm Delegate Stephanie Smith of Baltimore City, District 45. Over the past 3 months, the impact of COVID-19 has turned many of our lives upside down in Maryland. We have faced over 60,000 cases and over 2,800 lives lost to COVID-19. Here with a special message is Dr. Lena Wen, the former health commissioner of Baltimore City and a visiting professor at George Washington University.
Well, first of all, I want to thank Delegate Smith and Delegate Wilkins for convening this important conversation. You know, we know that here in Baltimore and all across the country that we face profound disparities, that COVID-19 has unmasked many of these underlying disparities. In our city in Baltimore, a child born today can expect to live 20 years less or more, depending on the neighborhood, the zip code that he or she is born into, and depending on the color of their skin. And that's just not a reality that we should tolerate. And COVID-19 has unveiled these underlying disparities because it is essential workers who may be living in crowded conditions and don't have the privilege of social distancing who are disproportionately affected. And we know that African Americans and other people of color already bear the brunt of health disparities. And because COVID-19 affects those with underlying conditions, you've got environmental injustice and food deserts contributing to chronic conditions that now are contributing to having the most severe effects of COVID-19. And this is why the call needs to be urgent right now for us to address COVID-19 as a crisis, but also to address racism, structural racism, and these underlying inequities too as public health emergencies. Yeah, so as we hear that states are reopening, sometimes there is a misunderstanding that it's now safe. Well, actually, the virus has not changed. It's still highly contagious. And actually, as people are up and about even more, it's even more important that we are on our guard. And so keep on doing the things that we know work to prevent transmission of COVID-19. Wash our hands very well, soap and water for 20 seconds. If you can't do that, use hand sanitizer. Make sure that we wear a mask when we're going to be around others, because wearing a mask protects us, it protects others around us. Some studies have shown that it reduces transmission by as much as 50% to even up to 90%. And importantly, keep that physical distance, that 6-foot distance between you and others as much as you can. Now, I recognize that everybody wants to ask about what's safe and what's not. Nothing that we do is 100% safe or unsafe, but think about our risk as being cumulative, that it's additive. So if you now have to go to work, reduce your risk while you're at work, but also don't do everything else just because you have to go to work. Doesn't mean that you also need to go to a restaurant and go get your haircut. Just because you're going to get your haircut doesn't mean that you now have to invite 20 people over for a dinner party. This is still a time that we have to be on guard, because it's only by protecting ourselves that we're able to also safeguard everybody else around us too.
Thank you, Dr. Wen. You're absolutely right. We are in the midst of a deadly pandemic that is disproportionately killing Black people in Maryland and across the country. And it's significant that we're having this conversation right now as the nation is reeling from police violence after the murder of George Floyd and other Black men and women. The combination of the pandemic and national uprising have brought the nation to a reckoning on the value of Black life in America. On your screen, you will see how disproportionately African Americans in the state have been impacted by COVID-19. Prince George's County is leading the state in COVID-19 cases, followed by Montgomery County, which is the area I represent, and seeing these numbers is truly heartbreaking. These aren't just statistics. They are real people who've made contributions to their families and their community, and we grieve for them and the loved ones they left behind.
Members of the Legislative Black Caucus of Maryland have been personally impacted and stand committed to securing the information and resources to combat the spread of COVID-19. Today, we will learn from a wide array of experts and civic leaders on how we can better protect our communities and prevent adverse effects from a future threat.
We welcome all those who are watching us on YouTube, Facebook Live, Twitter, Instagram, and other social media platforms. If you'd like to join this conversation, ask a question, you can use the hashtag awareness to action. It's one word, and let me repeat it, awareness to action. So let's begin our conversation.
How did we get here? Well, we're going to answer that question by beginning with Delegate Nick Mosby of Baltimore City and Dr. Joseph Wright of the University of Maryland Medical System, Capital Region Health. Dr. Wright, you've chronicled the history of health disparities. Can you give us a little bit of insight about that?
Well, first of all, let me thank the Legislative Black Caucus for having us this evening and hosting this very important program. I do need to give a shout out to the chair of the Legislative Black Caucus, Delegate Darrell Barnes, who is my representative in District 25 in Prince George's County. And I think it's important to, as Delegate Wilkins mentioned a moment ago, to understand the connection between race and what we're experiencing now with the COVID epidemic. It is obviously not a coincidence that the impact is disproportionately affecting our communities. And there is a long history and a long science behind the impact, the adverse impact of racism in terms of the development of chronic illness and chronic illness being the seed for health disparity. And what do I mean by that? Dr. Wen, in her opening remarks, talked about how the diabetes, hypertension, COPD, chronic obstructive pulmonary disease, the impact of these underlying conditions which disproportionately impact our communities and certainly in the health system that I am the chief medical officer for, this is something that we deal with every day. And this is pre-COVID, pre-pandemic. These are the kinds of challenges that we face in our community, and add on top of that the nature of the COVID virus, which is a novel virus. Our species as a human beings have never seen this virus before. This is why it is having such a devastating effect on all communities, but disproportionately African American communities and communities of color. So we got here as a function of the challenges, the adversity that we face as a people have faced historically for the last 401 years. There is no doubt that the impact of adversity has an epigenetic effect. And what I mean by that is the environment that many of our communities live in and are challenged with over the course of generations has had an impact and does have an impact on our biology. And I think it's an important discussion to have. We've heard much terminology over the last couple of weeks about racism as a public health issue. Well, indeed it is. And there is not only a social basis for that, but a biologic basis as well. And we got here not as a function of what has happened over the course of the last 3 months with the pandemic, but what has been impacting our communities for generations. And I think it's important to understand that. It's important to address this from the standpoint of prevention and mitigation. And it's also important to have our communities understand the roots of the disparity and why our communities are disproportionately impacted.
Thank you so much, Dr. Wright. And as we think about and make the connection between how we got here, one of those reasons is one of our good friends and our colleague, Delegate Nick Mosby, who's our colleague on the Ways and Means Committee in the House of Delegates. And Delegate Mosby, you were really one of the first in the nation to really champion the issue of the racial disparity and really work to ensure that we have data based on race and ethnicity. Can you tell us a little bit more about that?
Well, we know that with anything, when we disaggregate the data, unfortunately, Black and Brown communities, particularly in poor areas, have disproportionate impacts. I know this from my own personal experience. Very open. My father died when I was 14. All of my grandparents were dead. I was the first person in my family to go to college. They were all dead before I graduated from undergrad. And my mother died when I was about 30 years old. So, this is not a unique story to me. This is a unique story to everyone. We heard Dr. Wynn talk about life expectancy, particularly in places like Baltimore City. And we know that there's so many underlying effects because of that, and that's the byproduct of those effects. But the problem is when, as everybody has stated, and everybody will continue to state, when you couple that with something like this virus on top of the cardiovascular issues, on top of respiratory issues, on top of diabetes and hypertension, we know it could have damning effect. And we've seen that drastically in our community. So as I saw the numbers start to creep up and I started not seeing, some of the data, I quietly started trying to work with the administration to understand when were they going to disaggregate it by race, ethnicity, and then also zip code. And it was a very hard and arduous fight. I was lucky enough to have over 80 of my colleagues in the Maryland General Assembly finally sign off to a letter that I sent personally to the governor. And with much of that pressure, the state started to release some of the race and ethnicity data. And then as I continued to push and press, and it got national attention, the state started to release some of the zip code data. And as soon as that data was released, we saw that the number one zip code was actually in my area in Northwest Baltimore in the 21215 zip code. So, these are the things that we must get past. I mean, the fact that, we're still scratching, we're still fighting, we're still asking for disaggregated data is a problem in 2020. The last thing I'll say is, when government, whether it's local, state, or federal, is deciding what it's going to do with limited resources, typically the underprivileged, the underserved communities, if they don't have a voice in the room, if they don't have actual data to prove, to kind of dictate the way policy should go or the absorption of those funds to impact those communities should go, typically they're forgotten. And I did not want our communities to be forgotten. I didn't want it to turn into an op-ed or some white paper in a couple years of how we failed on the coronavirus because we skipped over certain communities or we didn't properly prepare to put them in. So the whole idea behind the data was ensuring that we had engagement, ensuring that we had testing, and ensuring that we had treatment on an effective and equitable level. And that again, we should never be here again.
Thank you, Delegate Mosby. We really appreciate your leadership on this issue and ensuring that we have the data necessary to really be able to take action. So for our two guests, one of the questions that we have coming in for you is that you both talked a little bit about data and talked a little bit about the racism connection. And because this event is really focused in on how we get from awareness to action, what's next? What is the call to action that the two of you who've really helped to lead on this issue have for our listening audience?
Well, if I could just start with emphasizing what Delegate Mosby just talked about, the need to continue to disaggregate data place-based. You heard Dr. Wynn talk about the impact of place-based awareness, and I firmly believe that we must continue to track with a fine-tooth comb what is happening at the community level, because I'm very concerned that we don't completely understand the factors that are influencing the expression of this virus. I will say that in Prince George's County, where after Delegate Mosby's district, the next 5 impacted counties are located, the zip codes are located in Prince George's County, and Prince George's County across the nation is the number 22 out of 3,000 counties, the 22nd most impacted county in the country. And we have to understand at a very, very community, neighborhood level, what are the factors that we need to address to protect people and address mitigation strategies. We must move from response to reaction to protection and recovery. And so in terms of next steps, I really do believe we have to support our local health departments. We have to provide them with the resources, not only for continued testing, but to address contact tracing, to really input the mitigation strategies that are so fundamental to Public Health 101, so that we're not back in this same situation in a couple of months. And one thing I want to stress is that we cannot, as a community, neglect our ongoing healthcare needs. As has been talked about, we are beset as a baseline with health disparities and chronic underlying conditions. We can't sit home and not address our hypertension. We can't sit home and not address our kidney disease. We must be able to infuse confidence in our healthcare systems that folks will come in. This is something that I'm very concerned about in our communities, as folks do not come out to the hospital, to their place of either primary care or ambulatory care for the underlying conditions that have really fueled this pandemic in the way that it has. And I just want to stress that, and particularly as a pediatrician, I want to also reach out to our families with young kids. We cannot neglect the need for their immunizations and vaccinations around the normal childhood diseases that are still ongoing in the midst of the pandemic, lest we'll have a rise in those diseases. So again, I would just stress that we, from a policy perspective, really need to support local health departments to address mitigation at the neighborhood level. And also for our families and folks in the community, let's please not ignore the health conditions that require ongoing care. And we are here as the health providers across the state to continue to take care of those needs, as well as continue to address the pandemic.
I have a question. I think one of the things that we think about when we think about healthcare is access to insurance. There are many people that have not been engaged in the healthcare system because of a lack of access to insurance, and also for some of the reasons you've mentioned, not being comfortable even receiving healthcare. We do know there's issues of unconscious bias and other forms of discrimination that make it difficult for some people to feel comfortable in the healthcare setting. What do you have to say to our Marylanders who maybe are hesitant to seek help to maintain their health in general?
I mean, at the end of the day, particularly with concerns like this, if it's not treated, if you're not taking care of yourself, it's only going to worsen. And we've seen that it's going to worsen to the point of death. And we've seen that rapidly throughout our state. The one thing I would like to say is, in tying in everything, is that, at the end of the day, it's about all of us waking up. It's about government waking up. But it's also about healthcare professionals waking up and understanding the fact that there's been tremendous amount of implicit bias, as well as structural racism that's been embedded in our medical system for far too long. That goes from research and development all the way down to bedside care. And we must come out of this and understanding and knowing if it wasn't for this COVID-19 that really forced all of us to be locked into our house, to be afraid, to be worried about our loved ones, we would not be here talking about something that we've known about for generations, and that's the health disparities in this country. So what we need to do now is grab the bull by the horns and ensure that we're focusing on this, looking at this from an environmental justice perspective. We look at places like Baltimore City, particularly West Baltimore, and the lead paint poisoning issue. When we look at places like having incinerators, that's the poor Black and brown communities. When you look at subpar housing, when you look at lack of resources for food deserts, all of these things are clear attributes and variables into this very complex equation of why we have these disparities. And again, we need to leverage the will and the compassion that we're getting coming out of this and going into maybe another round of attacks on this virus and ensure that we never get back here.
Christina on Facebook, I think, wants to kind of piggyback on what I lifted up, and thank you, Delegate Mosby, for that, because you're right. We already knew about these problems, but now we're focused on having the conversation. Christina on Facebook wants to know more about how the access to health insurance is adversely impacting Black Marylanders, and perhaps Dr. Wright can shed a little more light on that.
Sure. Well, I don't think this is germane to just Marylanders. We recognize that the lack of health insurance or being underinsured is certainly a factor that impacts access. And when we look at those factors that contribute to health disparities, the actual access to a healthcare facility and the medical care provided in that healthcare facility is but a small part of the contributing factors to health disparities and the effects that we see with chronic illness. One thing I want to emphasize, particularly for the state of Maryland, is that we have a robust system of federally qualified health centers across the state. And particularly in Baltimore City and in Prince George's County, the absence of insurance or being underinsured should not be a barrier. There has been tremendous investment in our federally qualified health center system such that access to care at these FQHCs, as they're called, is a route to access not only to primary care in the community, but also the FQHCs must have a relationship with the healthcare systems such that if there is a need for referral or specialty care or hospitalization, these FQHCs have a relationship with our health systems. So I would certainly, for the viewer who asked the question, concur that the absence of insurance or being underinsured has historically been a barrier to access. However, here in the state of Maryland, we do have, again, a robust system of local neighborhood-based federally qualified health centers that will care for individuals without regard to the presence of health insurance, and certainly we can access those individuals in the hospital system through the FQHCs.
Thank you, Dr. Wright. Delegate Mosby, last word for this segment. You really started this fight. Tell us, where do we go from here and where the action is currently?
Again, I think one of the biggest things is, since we have most of the data, not all of the data that I've been fighting question for, but it's really trying to leverage that in a way that we completely change the trajectory of the discussion. We've constantly called on and asked for, us to develop maybe a commission around health disparities so we can go after and look at the disaggregated data, because sometimes the data in Baltimore City is going to be completely different than the way it looks in Howard County, which would be completely different than say, Prince George's County. So really a statewide task force of a commission of looking at that data. It's also really important that when we talk about the impact of this, that the absorption of that money that goes towards the impact is going proportionally to the areas that have been affected the most. That's really important to leverage the data that way. And then lastly, when we come out of this, not just from a lens of medical or healthcare system perspective, but also the impacts of communities. When we talk about our small businesses that have been struggling, when we talk about the essential employees that have been literally scrubbing the hospital floors to provide us with transportation, to ringing up our groceries at the stores this entire time. Understanding and knowing that in the state of Maryland, when we fought to raise minimum wage, when we were calling folks minimum wage workers or low-skilled workers, now they're our essential workers, literally standing at the front line, ensuring that we're providing the protective measures as well as hazard measures to ensure that when we get into the situation again, that they'll be addressed. So, I think when we look at it from a holistic perspective, those are the things that must come out of this with to ensure that, again, we go after the health disparities, we stick up for our low-wage workers, and we go after some of the systemic issues and socioeconomic issues that have affected these communities for far too long.
Thank you, Delegate Mosby. We are just going to keep going with our questions because we actually have gotten another one in from Facebook from Wanda. And I think it's significant that we are getting so many questions on health insurance in particular. So Wanda from Facebook wants to know if the Maryland Health Connection plans, they're free and low cost, are those plans effective and are they accessible, and can people access them in order to get tested and receive health care when it's related to COVID-19?
Let me just say, in my role as a chief medical officer, the doors are always open at our facilities in the University of Maryland Medical System. Certainly, vehicles like Maryland Health Connection and testing itself, by the way, at the testing sites that have been set up around the state are accessible without having to present evidence of insurance. But I don't want people to be sitting home if they're symptomatic, concerned. We need you to be evaluated. I do not want individuals to certainly be sitting at home and worrying about this. There is a provision called EMTALA, a federal provision that requires us to evaluate anybody who comes through our doors. And it's really important. I just want to really stress this, that in the context of what we're dealing with now, we don't want individuals to not be evaluated because of concern about insurance or other concerns. We're here to serve you. The University of Maryland Medical System, with 12 hospitals around the state, all of our emergency departments and ambulatory care facilities are accessible and ready to take care of you.
Thank you so much, Dr. Wright. We have another question, so gentlemen, please don't run away. Zeb from Facebook wants to know, what other policy initiatives can we help to enact to protect our communities?
I think some of the policy that sometimes gets caught up and we don't go after is, when we talk about our environments, when we talk about environmental justice. So, like I spoke of earlier, the state has made tremendous strides, particularly in places like Baltimore City, to go after and ensure that we're getting to children that might be affected by lead paint. But there's so much more that we should do and that we have to do. Over this past couple of years, I've consistently put in a piece of legislation to say that the manufacturers of lead paint that knowingly sold this lead paint that was applied to many of the homes in Baltimore City, who've made billions of dollars off of this, have not paid 1 cent to eradicate the current issue. When we talk about, again, the incinerator, right now the incinerator is allowed to get tax credits that's essentially there to clean up the air. Well, we know that can be further from the case of what an incinerator does. So I think that from a policy perspective, a lot of things that we can do, particularly go towards environmental justice of providing a more clean, more healthy, more wealthy communities. And then one struggle that we constantly have is access to quality food, so food deserts. I know that a delegate down in Prince George's County, Jess Lewis, has done a lot of work on trying to bring quality healthy foods to his communities. I think those are the types of things that we need to look to expand throughout the state of Maryland.
Well, thank you so much to our audience for those questions, and we are so grateful to Delegate Mosby and Dr. Wright for taking the time to be with us and answer those questions. Coming up next, you don't want to miss it, our next section really focused in on what you don't know could kill you, and we're going to really get into the data and the impact of the racial disparities here in Maryland.
Has not been a great situation for me. I was used to leaving out, going to work, going to church, going to dance rehearsal, so I was forced to stay in the house. And staying in the house, I went through some mental challenges where I had to actually start seeing a therapist again, because I'm a people person and I'm used to being out and about and helping people and dealing with people. I'm great now, but when it first happened, just the anxiety of it was overwhelming. And I'm better. out and about a little bit, so that actually helped. And the teleworking was just, oh my God, it was crazy. Trying to figure out a schedule where I can actually telework and get some things done. It's even harder to telework at home. But right now I'm doing great, and I thank you for this time.
We said we would provide you with the facts. And in this conversation, we have a group of experts who know the information that we all need to know. We are joined by Dr. Sharita Golden, the Chief Diversity Officer at Johns Hopkins University, and Beth Blower of the Center for Civic Impact at Johns Hopkins University. According to data released Tuesday by the Centers for Disease Control and Prevention, people who have chronic medical conditions such as diabetes, lung disease, and heart disease face an increased chance of being hospitalized with COVID-19 and put into intensive care. Dr. Golden and Beth Blower, can you please talk to us about the data and the information that is available? Let's start with Beth to take us through some of the data that's currently available in Maryland and what we are seeing when it comes to the racial and health disparity. And I want our listening audience to know that if you are in the Facebook live chat, we will be posting her full slides in that chat so you can take a look at the information as she is speaking. So thank you so much, Beth. Let's start with you.
Great. Thanks so much for having me. And also thanks to the Legislative Black Caucus of Maryland for putting on such an important event. I'm going to talk a little bit about the data and just do the setting the stage, and then Dr. Golden will come with other key and critical public health information. Is much more qualified to talk about that. But I just want to start by saying that the World Health Organization recommends, before we start to think about relaxing some of the social distancing policies, that states are within or below a 5% threshold, meaning that of all the tests that are taken for COVID-19, that only 5% or below are actually positive. And just to set the scene, Maryland is not at that threshold. So we are hovering around the 7% test positivity, and that is certainly really sort of driving some of the decision making, but something that members of the public should be taking into consideration. While cases are going down and hospitalizations are going down, you are certainly still seeing data. And so the slides that are going to be circulated throughout the presentation are very high level. But again, if you want to see the full deck, you can get them in the Facebook, and we can certainly provide them. The thing that I think is very important to emphasize is that this disease is very clearly disproportionately affecting Black Marylanders. The percent positivity in this data that you're seeing now, the underlying color of the map is correlated with the population of Black Marylanders. And then the size of the bubble will show you how widespread the positivity rate is and where the disease is. And you can see that hugging the DC region and also in Baltimore, you have significant case activity. One of the things that we're also taking a very close look at is testing availability. Testing availability is still incredibly restricted. So there are two different ways that people can get tested. There are public testing sites that you can go where you don't have to have any proof of insurance. They are free tests where you can go in and you can get your test. And then there are sites where you have to go, whether it's an urgent care or something like that, where you have to pay to get that testing. Testing right now is incredibly limited, particularly in Baltimore City, for people that need testing. So at a per capita level, the state-sponsored free testing is only at one site. That is completely disproportionate to the surrounding Baltimore counties and certainly to the counties that are hugging Washington, D.C. area. The county case rate, again, is certainly another area that we're looking at, and it has, again, disproportionately affecting areas that have more significant Black population. The death rate, again, is also very much having a negative effect on Black communities, disproportionately as opposed to white communities. And when you get to even a more granular level, at the zip code level, you can see, particularly in Baltimore, in the regions where we're more accustomed to seeing a lot of the health disparity data and a lot of the other sort of social impacts that are happening in Black communities are also disproportionately manifesting themselves in the disease data as well. So if you look at the zip code data in Baltimore, you can see that in East and West Baltimore, there is significant disease involvement, and in the sort of white corridor that goes up the L that we frequently look at for lots of other economic and social indicators is, again, we're seeing that the disease spread is disproportionately in Black communities. There is also still a significant issue, and I think that in the previous panel, Delegate Mosby really has been a real force in getting information out, but there are still a number of counties that are not reporting race data on their local dashboards, and that is specifically important because even those that are not doing a comprehensive job of it. So in Baltimore County, for example, you can get data broken down by race for cases, but you can't get the comparable set by rate for deaths that are occurring in that county. And likewise, we're seeing that across some of the other areas in the state. There's also huge disproportionality for Latino residents that should also be looked at as we look at particularly in Anne Arundel County, Baltimore County, and Baltimore City. And then the last piece that I think we should really be focusing on is the reopening. So the reopening is occurring. We've already started banning a lot of our social distancing policy, and it's happening in the places where we're still seeing widespread spread of the disease, particularly in these disproportionalities for Black communities. And so we are putting workers at risk. We're putting families at risk when we think about these policies. And we also know that there are real economic constraints about staying home. And so are we actually creating the social supports that are required so that people can make the right decisions for the health of their families, particularly when they are at higher risk levels for contracting the disease? And is it consistent with those WHO guidelines where we see testing positivity below that 5% threshold? The last set of slides in the deck are really about our prison population. In Maryland, we have overrepresentation of Black Marylanders that are incarcerated, and testing and case data is still manifesting itself in the same ways in the prison population. This week, there have been at least 234 cases confirmed in jails and prisons in our state, with staff and the prison population being impacted. And I think that that's something that we also need to pay close attention to when we start thinking about the disparities. So that's just really some scene setting, and I really want to hand it over to Dr. Golden, who will be doing talking a lot more about the sort of significance of all of this information.
Thank you so much, Dr. Golden. We'd love to hear from you.
Yeah, so I just want to thank Beth for really setting the stage for us to really understand the demographics and the disparities and how they're distributed across Maryland. And I think that just to expound a bit on the real impact of coronavirus in the African American community, if we look at the deaths that we've had in the U.S., so there have been almost 120,000 deaths now because of coronavirus. And if we look at those, just over 21,000 of those deaths have been in African Americans. So, we're looking at a fairly high death rate of about 19%, and that's compared to African Americans representing about 13% of the U.S. population. So, very disproportionate. And in particular, Washington, D.C., which is in a region in our area, has like the highest death rate of African Americans of anywhere in the United States. And so, these are really important data for us to really cause us to really take action to determine what are the best approaches to protecting these communities. The other thing that I'll point out is that the death rate in Black Americans is about twice as high as it is in white Americans. So if everything was equal and there were not these disparities, we would now have about 13 to 14,000 more African Americans who would still be alive right now. And unfortunately, all of those individuals have died in the setting of this pandemic. And so as we begin to think about what other things that you need to know to keep yourself safe, I think that we get conflicting messages as we're starting to reopen that many individuals may interpret that as, well, if we're getting the message that it's time to reopen, then it must be safe to do so, and perhaps we can relax some of those restrictions. And what I would say is that they're almost a tale of two Americas, or two states of Maryland, if you will, in this pandemic. So, there is sort of the privileged part of the pandemic where if you look at those communities, the rates of infections, hospitalizations, and deaths are continuing to decline. But then there are those who are vulnerable. So for vulnerable populations, it's not clear to me, because this has not been looked at by race and ethnicity, whether or not the infection rates, the hospitalizations, and the deaths are declining in those most vulnerable groups, because that should really be another important consideration in our reopening approaches, not just in Maryland, but across the country. So if there's something else that I think is needed in our data, are really to understand whether or not those adverse outcomes are declining in the most vulnerable populations. If they are not, then that really should cause us to take a pause regarding our reopening, because in fact, by those who are not vulnerable could actually expose those who are more vulnerable to the coronavirus. So here are the things that I'm thinking about, and as an African American woman, I consider myself in a vulnerable population, is that it is really still important to wear a mask and wear the mask appropriately. There are a lot of times where we see the mask like sort of beneath the nose or down around the chin. It's really important to cover the nose and the mouth completely. In addition to that, when you have the mask on, it's still important to socially distance. So a lot of individuals feel that if they have the mask on, they don't have to engage as much in social distancing, but it is still really critical to engage in the social distancing. We have a 4th of July holiday coming up, and so we know that if you're going to be gathering with family, that it's better to gather outside than it is to gather indoors. Again, because the particles will disperse more widely outside compared to what they will do in an indoor setting. And then, of course, the hand hygiene remains critical during this particular time. I think one of the challenges for vulnerable communities that was pointed out is that if you look at a lot of our African American, Latino populations, many of our communities that are vulnerable are also in jobs in the service sector that have been considered essential in this pandemic. So, we're talking about reopening, but for some of those individuals, because of their occupations, for them, things never closed. So we have a large proportion of African Americans working in the service sector, so public transportation, security, food services, environmental services, health aides for nursing homes or at home. Many of these individuals still had to go out and work even in the pandemic. They did not have the luxury of working from home. So they have been continually exposed to COVID throughout this pandemic. So as we're thinking about reopening, remember, for a large segment of the vulnerable population, the state never really closed for them, and they still ended up being exposed. So I think that those are important considerations. I also want to point out that, we sort of have a public health crisis occurring simultaneously now with what I'm calling a second civil rights movement. And so, one of the issues, of course, that has arisen is how can people really be advocating for their rights? Many of the issues that we heard about in the last segment around structural racism that have contributed to health disparities, not just in chronic conditions, but in COVID, it's really important to be advocating for your rights, but it's important to do that safely. So important to wear a mask to the protest, protest. Recognize that if you take the mask off and you start shouting or you're around someone who's shouting, that particles can be carried further, and that creates a higher risk of infection. So making sure that you're wearing a mask, ensuring that you have hand sanitizer with you, and also making sure that your social media devices, your cell phone, is wrapped in plastic so that you're, again, not touching those surfaces and exposing yourself, after the protest is over. And so I think that these are really crucial elements that we need to be thinking about as we reopen. And again, just because the state has reopened and it's okay to sit outside at a restaurant and eat dinner, if you know you're in a vulnerable population, I would still be taking my carry out and taking it home, and I can tell you that's what my own family is doing. And so I think that those are really important considerations for our vulnerable communities.
Thank you, Dr. Golden and Ms. Blauer. I just want to give a moment for people that might just be joining us right now. Thank you for tuning in to the Legislative Black Caucus of Maryland and our event entitled From Awareness to Action. And if you would like to ask a question to us or any of the panelists, please use the hashtag awareness to action. We've had some questions come in via Facebook. I believe these are questions that medical and research professionals are probably asking themselves as well. Karen on Facebook wants to know, how can policymakers engage the community? I believe that this entire vehicle is an opportunity for the Black Caucus to engage the community, but we know that medical professionals, hospitals, and researchers are also trying to find the best ways to connect the messages you're sharing with us today to the people who need to hear them the most. Do you have any advice or suggestions or any lessons learned from the work you've been doing in your respective organizations and centers?
Well, I mean, I think it's really important. First, I just want to thank the Maryland Legislative Black Caucus for putting on this event. And so this is a really important way that those of us who are physicians and healthcare professionals can partner with our legislators to make you aware of these issues and to partner with you in, writing legislation, suggesting legislation to address these issues. And so, in our last segment, we talked a lot about, the contributors to health disparities, sort of the social determinants of health, if you will. So we know, for example, that because of policies of redlining, predatory lending practices that happened in the post-Civil War era, that we now have residential racial segregation. And in those neighborhoods, there's inadequate access to healthy foods and green spaces and parks for physical activity, and there are more environmental exposures. And so those are the type of things that we as healthcare professionals can partner with our policymakers on to determine how to, legislate that we should actually have a healthy food choice option within so many blocks in a given neighborhood, just like we say there should be a fire hydrant this many feet on every corner. And so I think that those are important ways that we can partner. And of course, our community partnerships to make sure we're using innovative public health messaging to get the messages to the community. Because often for those of us who are health professional, we, because of the experiences that some patients have had within the healthcare system, they may be less likely to trust us. But if we can partner with trusted messengers in the community, like we've done with the Baltimore NAACP, and you'll hear from Reverend Colby Little in a subsequent segment, partnering with a trusted partner who can then send those important public health messages to the community is really, really crucial.
That's a really important point. We hope that all of our listening audience will engage with us as a Legislative Black Caucus as we move forward with policy solutions and also immediate actions based on this information that we're hearing today. We have another question that's coming in, but before we get to that, I'd like to take us back to the reopening because based on the information that both of you shared, can you actually talk more about what we would have liked to see before moving forward in terms of data when it comes to vulnerable communities versus what we are seeing, what the data is showing us, and sort of that gap and what we can do now since the state has been moving forward with the reopening?
Yeah, I think actually Dr. Gold made a very good point that a lot of the data that we're looking at in the context of reopening is not disaggregated by race. And so even though we're nowhere near the sort of 5% or below threshold for percent positivity of cases, we know that for those people that do actually have access to testing in the Black community, that may be a higher percentage and that information is not available. It's not available at the county level, and it's not available at the zip code level where we think we would like to see it. So I think would be, where is testing available? Who has access to it? What are the barriers that are standing between residents who are feeling symptomatic and whether or not they can get those tests? And then what does that percent positivity look like? So in communities that are vulnerable or at higher risk, do they have are they actually getting access to that testing, and are they falling within that safe threshold? Until we really are confident about whether or not we're at that 5% or level or below, we have to look at all the other indicators, right? We're looking at hospitalization rates, we're looking at case numbers, we're looking at all the sort of contextualizing data. But again, I think it's really critically important, because we now know that the disease is disproportionately affecting Black communities, that we're looking at the data broken down in those ways. And so we're making decisions that are not smart for sort of those that have the privilege of working from home or have a little bit more discretion in their decision making, but that we're making decisions that are smart for Black communities in particular, particularly those that are going to be hardest hit by the disease itself.
Yeah, I would agree with that. And I would also add that, the point that was made about the access to testing. And so, a lot of our state testing capacity has been focused on our nursing homes across the state, and then the drive-up testing sites, but recognize that a lot of our vulnerable communities don't have access to a vehicle, so they can't get to one of those testing sites. So this is when it becomes really crucial to have adequate deployment of mobile testing sites. I know that, at Johns Hopkins Medicine, we are partnering with the city health department and some of our community partners to, try to use some of our excess testing capacity to support some of those mobile testing sites in hotspot neighborhoods. But, again, if we're able to test in those hotspot neighborhoods and see that even in those neighborhoods the rates are going down, that would probably make more of us feel more uncomfortable about reopening. But again, right now, because we don't have testing sites deployed in all of the regions and neighborhoods that may be most affected, we really don't have those data right now.
Right, so we really need to focus in on the hot spots, on the disproportionately impacted communities, especially as it relates to testing, to make sure that there's access and that we have the data we need to really make sure that we drive down those infection rates. Thank you so much for those points. We have a question coming in from Janine, who is listening on Facebook, and she wants to know more about the infection rates and are Marylanders out of the woods in relation to infection rates.
Yeah, so that's an excellent question. And so I know for the last 3 months, I would wake up every morning and check my Weather Channel app to see what the rate of decline was, in coronavirus overnight. The rates are still increasing, but not by as much. So hospitalizations are going down. If you actually look at the rates, now it'll be like a 4% increase from the day before. So the rates are lower, but at the same time, they have not completely leveled off. And remember, we don't have full statewide testing deployed. So this is not based on all of the information on all individuals in our state. So I am concerned that we are not out of the woods. And in fact, we had Memorial Day where, people began to come out and perhaps were not as consistent in their social distancing and masking. And then we started to reopen, and then now we've had the protests occurring, and now we have a 4th of July holiday coming up. And I know that there was a lot of concern that we will likely see a second wave, if you will, in the fall that will also be compounded by when we typically see a rise in the flu. But I am becoming increasingly concerned that we may see that rise happen earlier than the fall because of the combination of reopening and the summer holidays and the protests that we've had recently. So I think that we need to be extremely vigilant, and we should have a low threshold for putting back into place some of the closures necessary if we start to see a rise happening again, because we know that if we start to see a significant rise in infection rates again, that it's still going to impact our African American community more so than other communities. And so it's going to be very important that we quickly respond to that if we begin to see it.
Doug? Go ahead.
Just because there are less positive, or there are less positive cases, doesn't mean there are still infections. If we don't see the testing rate going up, that just means that less testing is happening and less people have access to testing. And I think it's really, really important to kind of really emphasize this point, is because we don't want the state to relent on getting testing to as many people as possible, and that testing and having situational awareness over where the disease is critically important. And I think it's a real red herring when we see that testing positivity is going down, but we also are looking at less testing happening. We want more testing and that positivity rate to be going down. But right now we're experiencing less testing, which is actually a very big red flag.
Yeah. Thank you so much. I want to get some final comments from you, Beth, because I think the last point you made was a critical one. We have our president actually saying that he is frustrated with testing because then you find out that people have it. So, I mean, these type of mixed messages are very unhelpful for the public. But before you give us kind of your closing thoughts, I just want to confirm something that Dr. Golden mentioned earlier. There has been modeling that if the Black death rate was similar to the white death rate from COVID-19, there would be how many Black Americans still living with us? Maybe, was it 14,000?
It was 13 to 14,000.
13 to 14,000.
Mm-hmm. Wow.
That is so sobering. 13 to 14,000 Black Americans are no longer in their communities with their families because we did not necessarily do everything that we could have from the top down to kind of put things in place to better protect the public. And I think what's important about that is to remember that some of those deaths were also multiple in one family. Some people have lost multiple family members. So that's not necessarily 14,000 different families. Some families really absorbed this pain on another level. So Beth, could you give us some closing thoughts that you want our listeners and Black Marylanders and people who are just concerned about this particular disease? What do you want them to think about right now as they go about living their lives? As Dr. Golden had mentioned, many people don't always have a choice to work from home. It's a bit of a privilege that some of us participating in this panel have. There's been data to show that less than one in five Black Americans has the opportunity to even work from home with the jobs that they hold. So what are some things that we need to think about for people who do not even have that flexibility?
Yeah, I mean, I think we have to be eyes wide open on the fact that these policy decisions are being made around what's opening and what's closing and who we're forcing to go into jobs and who we're making re-engage in dangerous activities or risky activities, knowing that it's disproportionately affecting Black Marylanders. And so when we're thinking about that, I want to make sure that we're holding our public policy makers to account. That we are being clear, that we want to see the data, and we want to see that the decision making around what is being open and the sort of localization of that decision making is being driven by the best interests of the Black Marylanders that we have in our communities.
Because Thank you so much, Beth. That's the perfect place for us to stop. And we want to thank you and Dr. Golden for all the data and all the hard work you're doing. And we want to just continue to have this conversation. This is important, and we thank you for your service.
My name is Keteria Crowder, and I'm from Baltimore, Maryland. During this pandemic, I am a recent Hampton University college graduate. My school year, I felt like it was snatched away from me unexpectedly. During the time of this pandemic, I've been meditating, ensuring that my college education was fulfilled and made sure I graduated within my time. I kept my notes. I went outside to take a breather at some points. I exercised with my younger brother and made sure that I had a lot of family quality time that I didn't have in these past 4 years while being at Hampton University.
In this last segment, we will look at challenges, promises, and what tomorrow may bring. We will have two guests. We'll have Dr. Nicolette Lewis-Saint of Healthcare Ready and the Reverend Kobe Little of the Baltimore NAACP. Now, Reverend Little, we know that NAACP has been at the table making sure that not only its membership, but the wider public it serves are aware of the threats of COVID-19 and that they have an ally and a resource in the NAACP to make sure that they're spreading the right information to their neighbors, to their friends at church, and to their families. I know that there are some things that are not necessarily clinical or medical that the NAACP has been fighting for, and how they feed into the threat that Black Marylanders are facing with COVID-19. And I'd like for you to discuss some of that work and some of those issues today.
Well, I certainly want to thank Chairman Darrell Barnes and the Legislative Black Caucus of Maryland, as well as you two very fine delegates, Delegate Wilkins and Delegate Smith, not only for the work that you're doing around this program, but for the outstanding work that you did in the last legislative session and the leadership that you continue to provide, whether it's Delegate Wilkins and the homeowner and renters relief work, or the work, Delegate Smith, that you've been doing around the census. Certainly a delight to always to work with you and the members of the Legislative Black Caucus. So thank you for having me. The Baltimore NAACP has been engaged from the very beginning in working to mitigate the impact of this pandemic. So whether it is the work around preparing our communities for the special congressional election and the June 2nd primary, and the advocacy before the State Board of Elections, or the work that we did with the Mobile Public Health Education Unit to get the word out to our community to stress how serious this pandemic is. And I certainly want to give a shout out to Dr. Sharita Golden and her team at Hopkins Medicine for the outstanding support that they've given towards that effort, Media Minds, and so many others who have leaned in to help us to get the word out. Now, because of political and economic factors, we are prematurely moving into a stage of reopening. The threat of COVID is still very real, and it will continue to kill people in Maryland. We must now move from avoiding the risk, which is what staying at home allowed us to do, to managing the risk. So as we return to work, as we return to public activities, we must continue to be vigilant as it relates to the public health guidance, to cover our faces with masks or facial coverings, to wash our hands and avoid touching our faces, to keep our distance, and to stay at home whenever possible. So the NAACP will continue to have that message around Baltimore City with some retooling of the message, and we're looking forward in the very near future to rolling out a new component of the campaign where we distribute masks to help people stay safe during the pandemic. We're grateful to all the partners who have leaned in, and we invite others to join us at naacpbaltimore.org. You can give a contribution, or you can up your membership there. There are some considerations going forward as we move from awareness to action that we think are critical. One is moving to managing the risk. But then also, we think it's critically important that we address the economic security issues around COVID and the response. Too often in this country and in Maryland, our responses are driven by the needs of the economically secure and economically powerful. But the truth of the matter is, those people already have on their oxygen masks. When crises hit, we must do the planning with the most vulnerable in mind. And so we're calling today and in the future for economic security for the most vulnerable to be the point of departure. We saw that when Congress released the PPP program, it was the large, very secure businesses that gobbled up all of the money. The Shake Shacks of the world got the money, and the businesses in our community, black businesses, Black Business Matters, they weren't able to take advantage of that. So we certainly want to make sure that with a program of economic security, we see essential workers getting pandemic pay. We see housing relief as something that rolls out in the next month or so that as people become vulnerable to eviction, they have the resources to pay the rent. If they were vulnerable in March, they're still vulnerable now because we've all been under an economic shutdown. We certainly believe that there should be emergency paid sick leave in addition to whatever sick leave people were already getting with their employment. We think that it's important that the state begins to monitor the PPE supply so that we know that we always have PPE readiness throughout this pandemic. So if there's a second wave or if there's another crisis, we're prepared for it. And finally, I want to speak about the importance of guaranteed access to COVID testing. And I'm very delighted to announce that we've partnered with the Maryland Department of Health to make sure that there's free testing at the Baltimore Convention Center. So if you're in Baltimore or close by, we welcome you to come to the Convention Center at Sharp and Conaway between 8 a.m. and 2 p.m. on Wednesdays and Fridays, weather permitting. There you will be welcomed in a culturally competent way, and you'll be assisted to fill out the forms if you need that, and to get free testing. No charge to you. So testing is important. We will see more testing, but as the numbers change, because there is more testing being done, we should point out that this virus is still deadly. And the vast majority of people in Maryland have not contracted the virus, which means that the vast majority of people in Maryland are still susceptible to contracting the virus. Most of us are still in grave danger of getting sick as a result of coronavirus. And so we have to, even as we emerge from our homes, we have to exercise the public health guidance that will keep us safe. wear your mask or facial covering, wash your hand, keep your distance, don't touch your face. And remember that you can have the virus and not have any symptoms. So act in an affirmatively protective way so that you keep your family members safe as well.
Thank you so much, Reverend Little. I mean, we really rely on the leadership of the NAACP and other civic institutions to make sure that we're protecting the least among us, but there are so many people that really, they need this advocacy. And I think what you've been discussing is what equity truly is. If your policies and your procedures and your outlook are always thinking about the most vulnerable from the onset, you don't have to scramble to think about them later. So thank you so much, Reverend Little, for your advocacy. We now have joining us Dr. Nicolette Lewis-Saint, the Executive Director of Healthcare Ready, also the former assistant to the Ebola czar at the State Department. She is someone that is at the intersection of public health and emergency response. And we've been hearing from the beginning of our program with Dr. Lena Wen to Reverend Little just a few moments ago that what reopening says to the public can be confusing. And then there is a bit of confusion about what phase are we even in and what does a subsequent phase mean? When are we in a phase 2? Dr. Lewis-Saint, can you help our listeners just make sense of the phases? What do they mean?
Sure. And first, I just want to start by saying thank you all for having me. It is a pleasure to be with you, albeit remotely this evening. There are a few terms that are being thrown around. One of them is the phases. The other is waves. And I think even in this conversation, the idea of the first wave or the second wave continues to come up, and it is confusing. What we've seen with as it pertains to the phases has been a staged reopening plan. What that essentially means is that for every state, and this really is a state-by-state decision, that they are creating parameters around which they determine that there are sufficient health systems capacities as it pertains to the number of available intensive care unit beds, the amount of PPE that might be available, and then also the number of cases and the rate of increase. And as those factors begin to stabilize, we're shifting from phases of stay-at-home orders into gradual reopenings. It is not a function of how we are building immunity against the virus. It is not a function of having additional therapeutics or treatments available to help you actually fight the virus. It is simply a function of those parameters that really assess capacity. On the second and third waves, as we often hear people discuss, there is essentially a phenomena that when you're dealing with disease outbreaks, you deal with essentially a large number of cases, and then as things begin to stabilize, whether it be because of pharmacological interventions or medical treatments, or non-pharmacological interventions like staying at home, you begin to stabilize, and then you may see additional upticks. We are still very much in the first wave, and it's important for us to characterize everything that we're doing from the framing of there is no vaccine available yet.
That's right.
We are learning more about available therapeutics, but there is still no therapeutic for this coronavirus strain, this SARS-CoV-2. And there is no guarantee that having been infected with COVID means that you actually have immunity. So there's still a lot of data to be collected to actually help us to understand what reinfection looks like. From my vantage point, everyone, whether you've had COVID or not, is at risk of being infected again.
You actually bring up something at the tail end of your remarks, and thank you for them, is that, some people are saying, I'm not leaving this house until a vaccine's available. And that could be 18 months, maybe it could be a couple of years. I think people need some right sizing and some expectation management. Can you give us some insight into what people should be looking for in terms of a timeline?
Sure. And one of the things that I definitely want to make sure that we elevate in this conversation is the long history of participation of Black people in clinical trials. So not only should we be thinking about when the vaccine is available, but we should be thinking about driving towards policies that are helping to make sure that we actually have representation in the trials, because that's the only way we're going to have a vaccine or a therapeutic that works for people of color, is if we are participating in the trials. On average, it takes between 12 and 18 months in an accelerated pathway for us to have an available vaccine. It takes time. This research and development takes time. The first phases just deal with making sure that it's safe, and then it deals with the actual efficacy. Does it do what it's intended to do? And that takes time. But even once we have an approved vaccine or approved therapeutics, there's been a lot of discussion about supply chain. This is a supply chain production issue as well. We would then still need to have the capacity to build enough vaccine for the globe. We're not just talking about the US, we're not just talking about Maryland. We are going to know at this point that the entire globe is going to need access. And we're going to not just have production, we're then going to have the vaccination campaigns that deal with how we actually get the vaccine into communities, how we're distributing it out. And so if you think about each of these phases, they're all complex on their own. So when you pull them all together, it won't be a year before we're all vaccinated. And so this is, from my vantage point, this is a long haul. We are going to be in some version of this posture for a while, and it's in the interest of our public health and our security that we are getting our minds prepared for what that really looks like, because it will be at least a year until we're in a position where some of us will have access to the vaccine.
So you've just noted, some people are trying to make it day to day, hour to hour. They're just trying to keep their minds in that context. But you're saying we're going to have to kind of guard our minds and spirits for a long haul. And I think that is something that is running up against overly optimistic, I think, messages that we're getting from different levels of leadership that seem very engaged and kind of getting us back to a commercial reality that was pre-COVID, but with COVID, things are going to have to adjust. I want to bring you both into a conversation around something that hasn't come up yet, but it's part of managing this situation, is contact tracing. It's a phrase you hear people discussing, and there's an element there of not only helping us to stem the spread of COVID-19, but there's also an economic opportunity here. It seems that if Black Marylanders are disproportionately impacted by COVID-19, they should be able to participate in solutions that are paid to help people to stop the spread. Reverend Little, what are your thoughts on ways that we can better integrate Black Marylanders into the solutions, and especially solutions that provide payment and employment opportunity?
Thank you, Delegate Smith. I certainly want to also thank Dr. Lou Saint for the outstanding work that she does in partnership with the NAACP around our Emergency Management Task Force and keeping us healthcare ready. We appreciate the work that you do. As Delegate Smith and Delegate Wilkins know, I chair the Maryland Task Force on Reconciliation and Equity. And part of the work that we are shifting to do now, and I'm glad to announce that here on this program, is that we'll be calling for an equity recovery plan that takes into account what needs to happen for our response and recovery to be equitable. And certainly part of that is creating economic opportunity for people of color, for African Americans, for Latinx, and for others to participate in contact tracing, to participate in the supply of PPE, to participate in all of the various economic processes that drive response and recovery. So we will be reaching out to members of the General Assembly and local elected officials, as well as community stakeholders and individuals, to get your input on how Maryland can develop a plan of response and recovery that is equitable and speaks to the needs of our most vulnerable populations and leaves no one vulnerable or marginalized. So often we hear about health disparities. In fact, there was some shock or surprise from some quarters of the government when the health disparities in terms of rates of COVID infection and COVID mortality were made apparent. But the truth of the matter is that those disparities have always been there, and they don't just happen magically. They are the result, they are the health consequences of white supremacy and structural inequity. Tomorrow we will celebrate Juneteenth. And the message of Juneteenth 155 years ago was emancipation. We are in a transformative time again now in 2020. And the message today is equity. Everything that we do going forward must be done with an equity lens. It must be done in a way that rights all of the things that were wrong about the past. It must be done in a way that changes the structures that drive our society so that there are no longer people who are not included, so that diversity is no longer an issue, so that there are not haves and have-nots. It sounds like a radical idea, but if the recent events have shown us nothing, continuing on in the way that we're going is not sustainable. Equity gives us the sustainability that we need. So we invite you to join us as we develop an equity-focused recovery and response plan. And we encourage everyone to begin to talk about the health consequences of white supremacy and structural inequity. If we don't name the problem, if we don't own the problem, then we can't address it. If we continue to just talk about health disparities and say, don't know how those happen, then we'll never really solve the problems. So that's my challenge to policymakers at the state and local level, and certainly we hope that the members of our federal delegation who are tuned in this evening will also take that message to Washington. We have to start talking about the health consequences of white supremacy and structural inequity. Finally, I'd just like to say that as a community, people of color, and particularly African Americans, we have a long history of being marginalized and left with pneumonia when the rest of the country has a cold. And it's as George Bush said, fool me once, shame on you, fool me, well, he didn't get it right, but fool me twice, shame on me. And we ought not to be shaming ourselves, which means that we need to take responsibility for our community. And what that looks like is having a plan for resilience. We have to do the work in the African American community to develop our resiliency so that without regard for what the government does, pray God that they do the right thing. But if they don't, or if they're slow, or if they're resource strapped, we still have developed the capacity to be resilient. And that's part of the wonderful work that Dr. Lucent does as an emergency manager. And I hope that in the coming weeks and days, we'll be able to collaborate to teach our people what emergency management is all about, what a CERT is, and how we can build our resilience, both in terms of our economic capacity, in terms of our community connectedness capacity, and also our spiritual and emotional resilience. We've been through a lot of trauma, and we need to address the trauma that we've been through, and we need to address the trauma of these crises, the crises of the pandemic, the crises of police terror and police violence, and frankly, the crises of a limited democracy in a country that is supposed to have the fullest democracy in the world.
Thank you, Reverend Little. Certainly, equity and resilience are two of the key words that have to be at the core of the work that we do together moving forward. And I really want to lift up something that Dr. Lucent mentioned regarding it not being clear if when someone contracts COVID-19 that they are immune to it. That is certainly a myth. And something that underscores is that there's a lot that we do not know about this virus. And so I wanted to ask you to talk more about, when there's so much that's unknown, how can we make sure that we save Black lives? With the data that we're seeing around the disproportionate impact, how can we save Black lives when there's still so much that is unknown about this virus?
Sure. And I want to also make sure that I answer Delegate Smith's question on contact tracing, because I think that's a critical part of it as well. So as you all know, I dual hat between public health and emergency management, and so I'm going to do so in this answer. Contact tracing really is one of the basic tenets of epidemiology. What it does is it simply allows for us to be able to understand all of the individuals who have been in contact with a known infected person. Going back to the concept of the waves, the first wave, the second wave, the third wave, we are not out of the woods, but what that means is that we still have to make sure that we are maintaining and building a better response capacity than the one that we've had for the last few months. And so contact tracing being a basic tenet of that, we do have to make sure that we have those contact tracing individuals who are hired and have the ability to activate should we need them in the future.
Dr. Lewis-Saint, we have about a minute, so I just want to give you that guidepost.
Sure. However, we do have to make sure that as we are creating those economic opportunities, we're not putting people of color, especially Black people, at disproportionate risk. And so putting on my emergency management hat, I want to remind us that it takes about 30 years to have recovery from a catastrophic event. And so to Kobe's point, if we're thinking about the pneumonia, we need to be thinking about the long-term economic, the mental health impacts, and then the public health impacts, but making sure that all of the opportunities that we're providing to Black people are not putting them at disproportionate risk.
Right. So I guess my closing remark would be to invite people to visit the NAACP Baltimore City Branch Facebook page, where you can find a link to the Coursera online training that will give you certification to become a contact tracer. And the city of Baltimore and many other jurisdictions have programs where they're hiring people from the community to be contact tracers once they have this certification. So we certainly invite you to visit us on our Facebook page and also to visit our website, NAACPBaltimore.org, or to find us on social media at NAACP Baltimore.
Fantastic. Thank you so much, Reverend Little. I want to thank you again, Reverend Little and Dr. Lewis-Saint. In our last segment, we're going to really be ruminating on all the great information that you shared with us and also what other panelists have shared with us, because I think we have a lot to consider. I think that this has been informative for me, even in the preparation for it. I've learned within the past 90 minutes things I did not know before, and I know that folks that are listening in are learning as well. And I think it's really important, again, that we have the Legislative Black Caucus of Maryland holding up the banner of information that otherwise would not be coming to our communities. And I know that there's going to be additional segments like this or moments like this throughout the summer. And again, I want to thank you for your time today. And I want to turn to my co-host, Delegate Jheanelle Wilkins, to get her thoughts about some of the things we've been hearing.
We'll be back shortly with our final thoughts.
My name is Keyshawn Stewart, and I live, work, and have gone to school in Baltimore City. And how I've been able to survive is one, creating creative healing options for myself, my children, and my community. So one of the things that I've done is go for long walks in the park. I've been fortunate enough to live next door to a park where I've been able to go and dance, to invite the community out to do some dance, of course incorporating social distancing, to be able to go out and do some prayers, to orchestrate some different types of community gatherings, to provide items for persons that are less fortunate or maybe going through a hard time. So we've been kind of coordinating the resources from home. It's something that I love to do, been able to do it outside of my home.
So this has been a really fascinating discussion. I'm so thankful for all of our distinguished guests that joined us today. And I wanted to just ask you more, Delegate Smith. We've heard so much information. You just said you learned a whole lot. What really resonated with you about this conversation?
I think there are a couple of factoids that really I mean, they just kind of sit in your spirit. The one is the 13 to 14,000 Black Americans that have died, that if our, death rate was similar to the white, our white neighbors, they would be here. That's 13 to 14,000 people that are gone. That's something that's going to sit with me for a very long time. Another thing is what Beth Blauer shared with us about, yes, infection rates won't go up if we're not testing. This is the awareness to action. The action is getting tested, right, so that we really know what we're dealing with. So those are two things that are going to sit with me for a while.
Something that's really clear and resonating with me, especially as we're having this conversation about Black Lives Matter nationally, some of the data that has been shared and the information that has been shared is just so clear that our state is literally reopening and moving full speed ahead, even when the data is showing that we're either missing information or the information that we do have is showing that the most vulnerable communities, including Black communities, are not at a place where we need to move forward with a reopening. So as we think about and have this conversation around Black Lives Matter and saving Black lives in this pandemic, we are certainly seeing once again the need to reaffirm both in our policy and our action that our lives do matter. So I think that our work is ahead of us with the listening public to engage with the Black Caucus, with the NAACP, and the other distinguished guests that we have as part of this event to really ensure that our lives are lifted up and valued and protected throughout this pandemic and beyond.
Thank you so much, Delegate Wilkins. And I mean, you're just underscoring why we will need the voices and the support of the viewing audience to advance equitable and transformative solutions for this pandemic and beyond. We're all going to have to stay vigilant within our spheres of influence. And no matter how bored we may become, and I know y'all are bored, COVID-19 is not defeated through indifference. We are grateful to the leaders assembled today and across this state that are supporting their neighbors with science, relief aid, and love.
We really have the opportunity to reimagine policies that perpetuate racism and discrimination. The data and impact of this virus, it has to help us to fuel change and achieve equity for Black Marylanders. I mean, one thing that really draws inspiration for me is our historical leaders like Frederick Douglass, who said that if there is no struggle, there is no progress. And we're in a struggle right now to save Black lives, but we have the opportunity to make greater progress than we've ever made before. I want to thank members of the Legislative Black Caucus for their support of this event and our chair, Darryl Barnes. And finally, thank you to Maryland Public Television for their technical expertise and their production teams for making all of this possible. On behalf of myself and Delegate Smith, be safe. Thank you, everyone.